So good afternoon, everyone. My name is Omar. I'm one of the ST6s in intensive care medicine and emergency medicine. I know some of you know me, some of you I never met, but thank you for coming for the teaching. It hopefully will be around 45 minutes. I should not cross that mark according to Zoe, so I'll try to do it within 45 minutes. It should be shorter than this. So today we're just talking about a case. We'll start with the case and then shortly we'll go into a topic related to that case. So to start with, it's a 35-year-old male who presented to ED with 6 days history of feeling generally unwell. He had some fever, had flu-like symptoms, and had some diarrhea at the same time. I'm an ED physician by background, so I always like to start where the problem comes from, which is usually from ED. His initial assessment, he looked unwell, he sat up talking, his chest was clear, he was tachycardic at 123, his blood pressure was 155/62. When examined his abdomen was soft, he had some generalized discomfort, but nothing very specific, and he had soft calves and he had no rashes at the same time. Blood stopped coming up. Initially, an arterial blood gas was done, and as you can see there, the pH was 7.26. His CO2 was normal. Just remember, this is a millimeter of mercury. This is not the kilopascal that we're used to. He had a bicarb of 18.2. As you can see, a significant base excess of -7.7. And I'm just going to hide this so you can see the lactate of 5, IBM of 9. His CRP came back as a CRP of 155, white blood cells that are 18, hemoglobin of 142, had an AKI of stage 2, and had also doubled his ALT and AST, and had raised bilirubin at the same time. Obviously, as you can see, things are going, as he's a young man, things are not heading very well, because that's the first arterial blood gas that we got in ED when he arrived. After they've seen this blood gas, although this is not a very true case, but it's a combination of some of the true cases that we've seen, he was quickly moved from majors, moved to resus because of the blood gas and because of the worry of what was happening. And I think at that time, people start thinking of what is going wrong. As usual with everyone who's tachycardic in ED, he got an ECG. I don't know if I can hear people in LRI, but also people here in Glenfield. If anyone can tell me, what do you think is the abnormality with the ECG?
Trick question.
It's just sinus tachycardia. There is nothing more there, right? We can try to look into it a bit. There is some non-specific ST segment abnormalities, but none of them are specific. It's just sinus tachycardia. That was his initial ECG. Think about a typical differential diagnosis. Sepsis, we don't know where it's coming from. He's febrile, he's tachycardic, he had some abnormality in his abdomen, feels a bit tender everywhere, but not very specific tenderness. Have high lactate and had diarrhea, could be bowel ischemia, sometimes present like this. And he's a young man, so it could be a drug overdose at the same time. And as everyone comes through resus with a high lactate, with some abdominal pain, he obviously got a CT abdomen. So someone requests CT abdomen, they gave him some crystalloids, they gave him some IV antibiotics, broad spectrum, had an AKI bundle indicated, so had a catheter, requested a chest X-ray for him, and that came back as normal. CT was done, software pending, had a blood culture taken, and they asked for a surgical review just in anticipation if anything will come up out of that CT. CT report came back actually as normal, no evidence of bowel ischemia, no bowel obstruction, had the patent main vessels, and had some signs of liver congestion on his initial CT. ED lost interest, surgical team lost interest. I think everyone, I don't know if you've been to resus a lot, and maybe in this side don't go back to resus, but this is the classic patient that then will be cornered in a part of resus in one of the corners, having his antibiotics, having his fluids, and awaiting a medical bed, because medics will figure it out later, and because if you don't have a diagnosis, unfortunately, most of the time you'll end up under the medical team. Surgeons with a normal CT abdomen will never take you. And people did not think about it that much. And obviously shifts changed in ED, new team came into resus, and then 5 hours later, and 4 liters later, his EWS is worsening. The medical team asked for ITU involvement. He looks worse. He's struggling to catch his breath. He's now on a Venturi of 35%. He's pretty cold. His heart rate is now even faster at 145 beats per minute. His blood pressure started dropping, and now he has systolic of 92 and started within 155. And his abdomen is still soft and his calves are still soft. Any thoughts where we're heading with this gentleman? And that's for people online, in LRI, for people here.
Something cardiac.
Yeah. I would say that will the first clue because his. So if you didn't hear an LRI, I think we said something cardiac is happening at the moment. That's the answer I got from the room here. So he's not going toward the medics at the moment. We need ITU to come as that on the other side. I usually get those calls that this patient has been waiting in resus for hours. He did not progress as we want him to progress, and now things are worsening. And can we please get an ITU review before we get him around to the medical ward, because we don't know exactly what's happening. Especially if he already had a CT abdomen, because that's usually the second thing of delay. If you didn't get a CT abdomen from the beginning, he would be with the TARSA, or maybe you need CT his abdomen. So before ITU came around, they repeated his gas again. And as you can see, we have worsening acidemia, so pH is 7.15. He's breathing a bit faster with a CO2 32 and that millimeter of mercury. He's now on Venturi and have a PO2 of 75 millimeter of mercury. His basic stress is almost doubled or more than doubled since the last time. His bicarb is now even worse, and his lactate went up to 8, and his BM start going a bit higher. Also, his potassium start accumulating a bit. His chloride is rising, and that's not probably because he received some crystalloid with some chloride in them, which was not very normal saline. And we're trying to think where to go from here. What would you do if you were the ITU person coming to see him to LRI, in LRI ED, or you're in Linfield and you got to go see him CDU? What would be your next step? So yeah, good shout. So ketones are, his pH is low, his PM is high, ketones were normal, and that actually was done with one of the cases that this is based on. Those ketones were only, I think, 1.5, if I remember right.
Do an echo.
Yeah, so if you're Fusic hard signed off, if you're not, then put an echo on him. And that's what they did on the next bit. So you have systolic and diastolic dysfunction. There's no regional wall motion abnormalities and no pericardial effusion. And with that case, the next step, with the one that I was involved in, I spoke to my consultant because I wasn't sure where I'm going from here. And with the other one that what I know about is people start thinking about acute myocarditis. I think that was the main suspicion that we had, and that's what went down from there. And I think that's where the reason I went with the presentation in ED, because that is classically how those patients go through all those hoops until someone think about acute myocarditis, which most of the time, if you're 5 hours down the line, it's a bit too late for you to intervene as you need. So as you can see in the next slides, that we'll see why timely intervention and early intervention, early referral is very, very, very vital for those patients. So acute myocarditis, as it says in the name, is inflammation of the myocardium. The other name that you will hear from it is inflammatory cardiomyopathy, which is myocarditis with cardiac dysfunction. There's around the world around 1.5 million cases annually, but those aren't the reported and picked up ones, because it has a very wide spectrum of disease. So it's kind of very mild disease, which is you never present to the hospital, and it can be very severe disease that you usually end up in the ITU or end up dying. It's a disease usually of young men, and I would say young, because I think I'm still young, but it's usually between mid-20s and late 30s. Sometimes it comes to the late 40s. Mostly self-limiting disease, but as we will see shortly on the profile of presentation, it can be very mild, can be very severe and life-threatening at the same time. Causes, it's have infectious causes and non-infectious causes. Mostly when it's infectious, it's mostly virus. Parvovirus is usually P19, is one of the most common ones. The HHSV6 is one. Coxsackie group B causes a lot of myocarditis, but we don't see them because usually it's a very mild myocarditis when you see them. Although sometimes they present in children with Coxsackie B, Epstein-Barr virus, CMV, and adenovirus. And you most probably heard about the COVID during the COVID times. If you were working, there was a lot of mention about the COVID-19 infection-related myocarditis, but also the messenger RNA vaccine-related myocarditis. And just to stress that point, that still the risk of having a significant myocarditis from COVID-19 when you have an infection of COVID, and especially non-vaccinated, is quite significant. That I think the numbers is between 5 to 25% that you can get myocardial injury when you have severe COVID-19 infection, especially if you're not vaccinated. Within messenger RNA vaccine, the numbers that I've seen in the literature is usually between 0.3 to 5% that they will get. And usually it's a self-limiting disease when it's happened due to the messenger RNA vaccine leading to myocarditis. Bacterial and fungal infection can cause that. For the non-infectious disease, SLE, regular granulomatosis, I know it's have a new name, I couldn't find it, and giant cell arthritis and sarcoidosis, all of them can cause myocarditis. The important bit for us that in 50 to 80% of the patients that we see with myocarditis, we never find the cause. We send all this paper, those kind of investigation, we do all this kind of workup, but we never actually find what is the cause of the myocarditis. Stages, it goes into 3 stages. So we have the acute stage, which usually we'll be involved with as ITU, so 1 to 7 days. Subacute stages, 1 to 4 weeks, a recovery or chronic stages, more than 4 weeks. As we usually get involved with the first 7 days when they are presenting with the myocarditis, is usually it's due to the main organism attacking the myocytes and causing destruction on the myocyte. The subacute phase is usually due to the autoimmune disease that you get after that. And then the recovery or the chronic is something that the cardiologists see more than us because they usually present to them later on either with arrhythmias or either because they have been found by their GP to have an abnormal echocardiogram, and then they will find out that they had myocarditis or have a small persistent active focuses of myocarditis in their myocardium. We talked about the profiles, which is important for us. So the European Society of Cardiology have 3 profiles that usually present with myocarditis. So we usually can present what we call an acute coronary syndrome like myocarditis, and that usually a mixture between myocarditis and pericarditis. So they'll have chest pain, they'll have sometimes ST elevation on their ECG. When you actually do a PCI on them, you'll find they have normal vessels, and they'll be quite young patients with no risk factors. And then the diagnosis will come back as myocarditis because they did the whole workup for them. And the diagnosis for them with abnormalities on the echo is because they have this acute coronary syndrome-like picture. The other picture that they present with, and that's also we don't get involved with that much because they end up on the cardiology ward, is a new onset of progressive heart failure. So you will find that they don't have risk factors, they don't have any kind of genetic predisposition for another types of non-ischemic cardiomyopathy, and then they will find they have acute myocarditis. The third one, which is the severe life-threatening fulminant condition, this is the one that we get involved with. And this is the patient who died. If you don't actually suspect them, you don't refer them early, and the death could be within 24 hours. And 2 or 3 cases that I had been involved in before, which we had one recently, as you know, here in the unit, they usually die within 24 hours. And the one we have in the unit died despite being in a cardiac center and despite being referred, I would say, and almost in a timely manner. The other 2 patients that I had, one of them was in a DGH and another one was in Nottingham, and both of them also died because by the time we referred them to a specialist service, there was no option for them to go around, which we'll know about a bit more as we progress. So diagnosis, it's a clinical diagnosis. So especially in that acute fulminant picture. Do not wait for any kind of specific diagnostic criteria. The European Society of Cardiology have clinical and diagnostic and supportive criteria, but that is not useful for us in ITU because all of them will take a longer time. I think the useful bit from us is that we need to suspect it, and once we think about it, we need to try to do some bedside investigations, and the only useful one from that diagnostic criteria is a departmental echo or an echo by someone who's British Echo Society signed off to get us more information of what we can get off from a music point of view. I'm not going to go more into the ESC criteria because, as I said, using them in an acute setting, especially in the ITU settings or in the fulminant setting, they will just delay the referral. That is the main message that we want to get from today. So let's go back to our patient that now you've seen. You did the Fusic on him. You found out that he have this kind of systolic and diastolic dysfunction. What can you do about him to try to save his life? So you can manage him as a cardiogenic shock. So starting with bring him to the unit, basic monitoring. You can use what you need to use from vasopressor, isotropic support, dilators, depending on what you see on the bedside. Think about invasive cardiac monitoring, about PICO if you are not in a cardiac center, or the stuff that is more available in a cardiac center like here in Glenfield. Complete your workup. The important stuff that you need to do that maybe first thing will document that kind of suspicion or help you to support that suspicion is getting someone, either if you're an out of hours, either an echo radiographer or a cardiology reg to come and do a more advanced echo. Or if someone has the ability to do more advanced echo, as we have in some units, then can do advanced echo. Send the troponin, and troponin a lot of times come back in thousands because still it's myocarditis. There'll be damage to the myocardial cells and it will come very high. Do the viral workup that we talked about. So all that list of the parvovirus, of the EPV, the CMV, the adenovirus, send the workup, because even if it's not come back now, it will be useful later on when you speak to the specialist service and do the blood-borne viruses, because sometimes in advanced HIV, the presentation can be related and they can present as a myocarditis at the same time. And then you have to think where to go from here. Obviously, you speak to your consultant, but the important bit that ECMO should be the first point of contact after local management. And the aim is for VA ECMO or to facilitate transfer to a transplant service. And the reason being because they need to be supported through that cardiogenic shock for their myocardial to get better, for their myocardium to get better. And the more that you delay, and the reason it's time sensitive, that once they have end organ damage set in, and mostly, as you see, and as we've seen in the case that we had here recently, it will be in the form of AKI that will continue to worsen because of perfusion and liver failure because of the ischemic injury to the liver. Once that end organ damage sets in, then the specialist service cannot offer them a lot because they can fix or they can help them with the cardiogenic shock, but they will not be able to replace all the organs that now they have not got perfused for hours and hours as they are in the hospital.
How long does that tend to be?
So,
like the average myocarditis?
So I had the issue with the literature in myocarditis that there's not a lot of them. So the timing is very variable. But from what I've seen in experience, and I know there's some more senior than me on the other side than LRI, that the ones I've seen, it's usually within 12 hours. So the case I've seen in Nottingham, he came to the hospital at 10 p.m. He came to CCU in Nottingham at 2 in the morning. He got referred to ITU at 4 in the morning. He arrested in ICU at 8 in the morning before we intubated him. We intubated him, he was on CRRT, he was in liver failure. By 2 p.m. he was dead. Okay. And the case that we had recently in ECMO around here in Glenfield over the weekend, he came to the unit around 12 a.m. and he was on VA ECMO at 8 a.m. in the morning, and he died after 36 hours of that. So it's a very, very quick, and you'll see them, they'll be young, awake, compensating very well. They actually will have a higher blood pressure initially, but they will be extremely tachycardic. And then after a bit, what will happen, they'll start losing their blood pressure, going into cardiogenic shock, and then other organs will start to follow. And I think once you get to the multi-organ failure, then you lost the battle already. And if you don't suspect it and you don't think about it, and you see it's very classic that you see, like most of the cases that I read about before this talk is mostly young men. There's some young females. They usually don't have risk factors. They usually quite well. They had some viral illness that lasted up to 2 weeks, so 1 to 2 weeks before they come in, and they usually start deteriorating very quickly, and they usually have unexplained lactatemia. So there's another case that we were talking about when we had the patient over the weekend that ended up having a laparotomy, which is negative. And then when he went to ITU, had an echo, and then what he picked up, and then he ended up going to the transplant center, have an LVAD in place, and it survived. So, and he had the laparotomy quite quickly, coming through ED, laparotomy, ITU, then went to the transplant center. So it is something that of time. There's not a lot of them, but if you see them, you can actually save their life by thinking and referring them early. What a transplant center can do for them, can put a ventricular assist device, which can be left ventricular assist device or Impella. Both can be used as bridge for recovery. As you know, the Impella is it's shorter period, so it's days. The LVAD could be months until he gets the transplant or until he gets better. And the main reason that the transplant, the reason you speak to ECMO, because as I think I just knew from the ECMO consultants that not all the transplant center, I don't think almost none of the transplant center unless they have an ECMO service in the same place, they will offer you a transfer to go out and cannulate them and bring them to you. So sometimes the ECMO team have to be involved, go out, cannulate them, and not all the ECMO centers can do VA ECMO. So it will be like our center can do VA ECMO, so they'll go out, cannulate them, bring them into the transplant center as VA ECMO, and then after that go to transplant center, and then they will end up by that surviving. Poor prognostic factors, because the reason to know about them, because when you speak to your ECMO specialist, then it's some things to highlight, and this is usually the stuff that will kill them. So ventricular arrhythmia, which is understandable, the myocardium is dying or is inflamed. Right ventricular dysfunction, mostly they present with isolated left ventricular dysfunction. If they have the right ventricular dysfunction, it's usually documented that they'll have a worse outcome, because as you know about the LVAD and the Impella, they usually work on the left side. The LVAD can be bypass, so it can be both sides, but that will give them worse outcome. Prolongation of the interval on the ECG, so prolonged PR interval, QT or QRS are all bad signs. Severely high troponin, because more damage of the myocardium is happening. That's why you're seeing higher troponin. Multi-organ involvement is usually, once you get to that point, you're not coming back. Prognosis is quite excellent if the disease is recognized quickly. They have a 93% survival at 11 years or years meeting in one study. And it's important to act early because you can actually save them if you intervened early. There are other kind of myocarditis, which is the non-fulminant. They have a very obvious, even better, because once you get into the fulminant type, you have a worse outcome. But that's 93% survival was in the fulminant type if they survived the initial presentation to the hospital. And that's it. If you have any questions from me. Objectives that we try to achieve today is practical approach to patients suspecting acute myocarditis, myocarditis definition, causes and clinical picture, the initial management, and the referral to the specialist service and the advanced management. Any questions?
Why is it more common in males than females?
They think it's related to the hormonal difference between males and females. So the old man flu that everyone keeps laughing at, when you have a testosterone in your system, you have more inflammation compared to having less testosterone in your system. They think this is the reason. But like there is a difference, not a big difference, but the three I've seen, they're all males, but there is a difference. Any questions from online?
Did you say more steroid equals more inflammation?
More testosterone.
Oh, testosterone.
Yeah.
Okay. Fine.
It's also worth to mention that there is no role to steroids or anti-inflammatory in in the myocarditis, they found out that they worsen the outcome, so that they don't give them, unless they have an autoimmune disease, they don't give them any steroids.
Is the testosterone, more testosterone equals more information? Is that the explanation for the man flu?
Yes, that's the explanation for the man flu. Yeah, trying to convince my wife, Zoe. Don't mention it.
Fine. Thank you, Emma.
You're welcome.
So hi, I'm Ben, one of the anaesthetic trainees. I'm going to talk about a paper about the alpha-2 agonist for sedation trial. So this is the trial, and full disclosure, the paper, the results have not been published yet, but this is a paper for the protocol of the trial. However, please bear with me because it's a trial that's very relevant to us on ICU. We recruited some patients from the LRI, and data collection is finished, so hopefully the results will be published soon. So in a nutshell, what the trial was looking at was comparison of using clonidine or Dexmed for sedation over propofol. It was a randomized trial. Allocation was concealed. It was open label, phase 3, and pragmatic. So I think that just means it's like a real world application. It wasn't like in a test environment. And it was a clinical and cost effectiveness trial. The primary outcome of this trial was time to extubation. So looking at how long people were mechanically ventilated for whilst on propofol versus on clonidine or dexmedetomidine. There were lots of secondary outcomes that they measured as well. These included the incidence of delirium, the quality of sedation. So they were looking at the RASS scores and making sure that there wasn't too much fluctuation in those scores. The mortality, ITU length of stay, and then they even followed up patients at 3, 6, 9, and 12 months. And they looked at things like anxiety, PTSD, cognition, and quality of life. Their inclusion criteria was basically anyone within the first episode of, within 48 hours of the first episode of being mechanically ventilated. And they needed to be, or expected to be mechanically ventilated for at least 24 hours to be eligible for the trial. Exclusions included most sort of neuro indications for mechanical ventilation. I think the reason is their progression through their illness is determined by their neurological condition over sort of their sedation and mechanical ventilation. Other exclusions are bradycardic patients, because that is a side effect of the alpha agonists, clonidine and Dexmed, and those in liver failure, because they can't metabolize the drug. So going through the 4 CASP sections, the first section was the study design valid for a randomized controlled trial. So the research question was clearly formulated, and it was clear what they were trying to check. It was a randomized trial. Participants were randomized in a 1:1:1 ratio, so clonidine, Dexmed, propofol. That was done on a computer system. And all participants were accounted for in the study, so even those lost to follow-up were accounted for. So section B, looking at how methodological sound the study was. So it was an open label trial, so I guess you could say there was no blinding. However, with the patients being sedated, I guess they kind of were blinded to what sedation agent they were given. But the investigators and assessors were not blinded. The 3 groups were very similar, and they all had equal treatment, so every aspect of their care was the same except from the sedative agent they were given. A little half-time question / break. In the trial, as part of the cost effectiveness, they talked about the cost of each of these sedation agents. So I'll open it to the floor. For your average 70-kilo man, how much do you think it costs per day to keep him asleep on propofol?
£3? No.
So per day.
Propofol's cheap. Cheaper.
So to keep someone, a 70-kilo adult asleep all day on propofol, how much do you think that would cost? So 30, I've got 30, one more answer.
It's 50. I'm saying 50.
It's 15 pounds. Yeah.
Cheap.
Do you think clonidine is more or less than that?
Or
Or it's actually less. It's
only
only
less.
£8 a day. And then what about Dextor? More. So compared to the £15 propofol, do you think it's more? More. Yeah, £22. So the most expensive is Dextor, then propofol.
£22.
£22.
That is a lot cheaper than it used to be.
It might be a little bit more.
Yeah.
Yeah, the branding's changed, hasn't it?
I don't know where the people that wrote this trial, they might be sourcing their Dextor from
That is better.
somewhere
Quite
cheap.
cheap. Yeah.
Anyway, that was my half time. Moving on to the third section with the CASP checklist for this trial, looking at the results. It's fair to say there's going to be comprehensive reporting of the results because there's multiple outcomes that are going to be measured, such as time to extubation, their CAM-ICU / delirium score, the quality of sedation, looking at their RASS score every day that they were sedated, mortality, and all the anxiety, PTSD questions that they're asked on follow-up as well. It's a precise trial. They quoted confidence intervals. I read that it said one-sided 2.5% significance level, which I think is all right. And they listed detailed health economic evaluation and adverse events were reported. So finally, will the results help locally? So this was a UK ICU trial, so it's fair to say they are going to be relevant to us. And then the final question, should we change our practice? We will see when the results are published. So overall, good things about this trial are there's a clear research question, it's a randomised assignment, there's comprehensive outcome reporting in many parameters, and there's a detailed health economic evaluation. Perhaps not so good things are it's an open label design, but that can't really be avoided. And to be fair, the patients don't know what sedation they're getting, so it's kind of blinded. And the unknowns of the trial were the long-term effects beyond 6 months, because that's as far as that's as far as they're followed up to 6 months, and generalizability to non-UK settings because it was a UK study. So the trial provides valuable insights into the effectiveness of alpha-2 agonists compared to propofol, despite some minor methodological limitations, and it has potential for improved sedation practice in ICU settings. So although the results have not been published yet, hopefully, based on this information, you will know when the results are published if they're going to be any good or not, if you can trust them. And I think you can probably trust them. And that's it.
Fair enough. Okay, so I need to apologise because I thought that I had, it was presented at Critical Care Reviews in Belfast last June, and I assumed that it had been published. I clearly didn't read it properly when I sent it to you, but what do you guys, have you guys noticed any difference with clonidine and Dextor and propofol?
My limited experience is people are seem to be a bit more awake on clonidine.
Yeah.
than propofol.
Generally. Do you think it's made any difference to length of time? Not so much.
I've noticed that they tend to be longer.
They do tend to be longer on clonidine. Yeah, I think they do actually. But I also think that we deliberately choose clonidine when we know that they're going to be asleep for a while. So it kind of might be why.
It saves £7 a day.
Yeah, clearly. And it stops giving them lots of lipid as well. So they don't get propofol infusion syndrome, which people get twitched about. I've only ever noticed them get green hair and wee. I haven't noticed the metabolic acidosis and liver failure and stuff that is reported. Mike, I don't know if you can remember, from what I remember about the presentation for A to B, the results didn't really show one way or the other, did they?
No, from what I can remember, there wasn't any significant difference. It was just then taking into consideration the complication with Dextor, but I can't remember. I'd look back. I'd probably look at your note, but
I know they're at home, just because I knew you were sat next to me. Yeah, no, I'm pretty sure there wasn't much difference. There was a bit more bradycardia in the alpha-2 agonist, which is not surprising, but it didn't make a huge difference to length of time. So I think it helps in that I think we probably just need to keep doing what we're doing and doing it in a tailored way of not giving the same thing to everybody and trying something and seeing if it works, which is what we generally do anyway.